Cancer Guidelines in collaboration with the Ministry of Health. She also holds a position as a senior lecturer at the University of Nairobi. She is a member of the Kenya Society of Hematology and Oncology. Dr. Carrier continues to be an advocate for early diagnosis and treatment of cancer and is greatly involved in programs that focus on providing easy access to basic screening services to the underprivileged, including setting up oncology services at county level. At this juncture, I want to welcome Daktari to take us through today's topic on cervical cancer. Kindly remember to feel free to drop your questions under the Q&A and chat box. Welcome, Daktari.
Thank you very much. Thank you very much. Can you hear me?
Yes, we can hear you, Daktari.
You can hear me? It's breaking
Yes.
off a little bit. Come and connect my slides. So
yes,
I'm
we
very
can hear you.
privileged this morning. You can hear me?
Yes, yes.
Put my slides first.
Yeah, okay.
Dr. Carrier, your mic is muted on your end. We are not able to hear
Can you
you.
hear me now?
Yes, now we can get you clearly.
All right. I would like first to appreciate being invited to give this talk on a very important topic of cervical cancer. Cervical cancer is one of the leading malignancies in Kenya and a great source of morbidity and mortality in women. And it is very important to increase awareness because a huge difference can be made if our health-seeking behavior around cervical cancer were to change. So Zainab, I also welcome questions after my talk, and I will try to keep it as, reasonably layman, as, to be able to, pass on the message for this very, very important topic. So I begin my talk by just explaining that cancer or a malignancy is just a change in cells that leads to uncontrolled cell division. And I will explain how in cervical cancer, an infection with a virus we call human papilloma virus changes the cells over a number of years and causes this malignant transformation, which changes these cells and makes them able to invade other tissues around the cervical area, to the lymph nodes, and also the capacity to spread to other areas of the body, what we call metastasis. I hope, Zainab, you can be able to see my slides clearly.
Yes, we are able to see them.
Okay, thank you. So that's what happens in normal cell division. The cells of the cervix will divide and they'll be repaired in what we call programmed cell death or apoptosis. So if any cells become abnormal, they are cleared very nicely in a process we call apoptosis, and those that propagate are the ones that are completely normal, carrying out the normal functions of the cervix. Now, below that is what we call cancer cell division or uncontrolled cell division. When a pathologist looks under the microscope on a pap smear specimen, he will see abnormal cells in clusters that are rapidly proliferating and look totally abnormal, in shape, in size, and in what we call mitotic activity. So different words can be used for cervical tumor or cancer or neoplasm. Many people ask, if I stop eating meat or I stop drinking milk, will my cancer stop? But I'd like to emphasize today that cancer is progressive. It grows for no purpose because, our body sometimes gets hypertrophy. For example, if a paraplegic man is pushing a wheelchair, he gets hypertrophy of his upper limbs to be able to serve this purpose. But cancer has no purpose. It will grow regardless of the surrounding tissue. So cervical cancer will grow into the bladder and cause a fistula, will grow into the rectum and cause a rectal fistula, and it grows without any requirement by the body, and it is parasitic. Whether you eat milk or you drink, whether you eat meat or drink milk, cancer will continue to proliferate because it is a parasite. So cervical cancer is a big health problem. And I've put there just showing what some of the numbers are around the world. And there are different shades of blue showing what the incidence is. And you can see in the darker blue areas, Kenya being one of them, and East Africa, and the area of West African region, including Nigeria and South Africa, have very high incident rates of cervical cancer. And my emphasis this morning is that cervical cancer can be almost completely preventable. And that is why it's very important for us to change our health-seeking behavior, attend to it, and wipe it out. So in Kenya, with a total population of over 50 million, the number of cases of new malignancies is around 42,000 per annum. I must say that that's a very understated figure because of our diagnostic facilities around the country. But the one thing that I can emphasize is that you can see that in that pie chart, that breast and cervical cancer, even as whole figures, whole, incidence rates of men and women are very, very rampant. And we can see that the percentage of breast and cervical cancer, almost makes 23% of all cancers. And if you look at cancers among women, they are the most prevalent. Now, unfortunately, the diagnosis is made late, and over 50% of women diagnosed with cervical cancer will be dead within a year because of the late diagnosis. Now, cancer is one of the most common causes of morbidity and mortality, as I said. And if you look at cancer ranking second or third, after infectious disease and cardiovascular disease, and us saying that cervical cancer is the commonest malignancy with breast cancer, lumped together men and women, and also causing a huge health problem in women. So I've talked about, the new cases, the number of deaths, and those number of deaths being, in for example, 2010, I can tell you this is what is published, but currently these numbers are much higher because of the MEP program that was started by the ministry about 10 years ago, where there are better diagnostic facilities, access of pathology, even if this is still a tip of the iceberg, and we still have to do more. Now, around the world, it's the third most common cancer in women, because in Western countries, lung cancer and breast cancer precede it. And this is because a great job has been done in trying to reduce the incidences by screening programs. So this is around 1.4 million women get diagnosed with cervical cancer annually. And among these, 500,000 will be new cases, but over 50% of them will die of the disease. And 75 to 80% of these new cases are in developing countries in which, Kenya and Sub-Saharan Africa is. So in 1996, human papillomavirus was declared the major cause of cervical cancer. Human papillomavirus has many, many subtypes. And in 80% of cases, this is caused by the human papillomavirus number 16. So the human papillomavirus subtypes are allocated numbers and, up to over 50. And in 80% of cases, human papillomavirus number 16 will be isolated. In developed countries, the commonest are 16 and 18. In developing countries, we are 16 and 35 as a major cause. And other HPV types that are associated with cervical cancer number 31, 33, 51, 53, and 35. Now, the importance of mentioning this is the discussion around the human papillomavirus vaccine, which was rolled out by the government about 2 years ago, but had very poor uptake because of a variety of misunderstanding related with social, cultural, as well as religious issues. So after the WHO declared it a health program, very many screening programs have been rolled out in these developing countries. So that is just a diagram showing how the female reproductive organs look like. We have the fallopian tubes and the ovary. So a woman ovulates and the ovum goes through the fallopian tube into the uterus where it is fertilized, and the embryo embeds in the uterus and grows into a baby. So the cervix is just below at the upper part of the vagina, and that is where the cancer cells, as I demonstrated, will proliferate and grow into a solid growth that starts to bleed and cause pain and discomfort and discharge in the woman. Initially, as the cells are changing, if you look physically, nothing can be seen, and the woman almost has no symptoms or signs. And this is the stage at which we should diagnose cervical cancer. So this is how the cervix looks under a speculum exam when you go for a pap smear. Can they see this? Yeah, they can see this, yeah. This is how it looks under a speculum exam. The speculum is a gadget which opens up the vagina and the cervix can be visualized. So you can see the cervix, and that is already a tumor at the cervical area at the end of the vaginal canal. And that's how the tumor looks once visualized directly. And what the doctor will do, or the person performing the pap smear, even if it's the nurse, they'll take a tissue. There is usually a little bleeding after that. And thereafter, staging can be done to see the extent of this growth that you can see. I would like to emphasize that many times when the doctor looks at that cervix, there is no obvious abnormality. And when they take the tissue and the pathologist looks at under the microscope, that's when they'll see that there are some abnormal cells. So like I explained, the human papillomavirus infects the cervical cells and then starts to change them slowly over a number of years. 99.7% of all cervical cancers are linked to a previous infection with HPV. As I've mentioned, there are over 50 types, and I also mentioned some of the more common types that are associated with cervical cancer. So what the scientists have done is isolate 4 types that are most commonly detected, and this is HPV 16, 18, as I mentioned, and 35. And I've also mentioned that the early stages when the cells are being changed, you're completely asymptomatic. There is no pain during sexual intercourse, no discharge, no bleeding. You're completely normal. And this is the time that we should make a diagnosis so that we can intervene and cure the patient. So as the cells change, some of the common signs that later after a few years will be small pink or red warts, a bit of itching and burning in the genital area, sometimes even pain and discomfort during urination. So after the human papillomavirus has infected the cervix, sometimes the infection may remain quiet, stable, not changing as it tries to fight with the body immune system. It may remain stable for a very long time. You do a pap smear, there is no change. You do a pap smear after 3 years, there is no evidence of malignant transformation. Sometimes the infection may be overcome by the body immune system and regress spontaneously. Now, as the cervix, sometimes when the cervix is infected, it will not remain stable. It will not regress spontaneously due to factors that we call the host factors. the virus may change the cells into low-grade squamous intraepithelial lesions. So if a swab is taken and the pathologist looks under the microscope, he will write LGSIL on the report. And this is mild cervical intraepithelial changes that progress to neoplasia, which is cancer, or what we call early dysplasia. Dysplasia means changes in the cells that are tending to malignant transformation. So the changes are very gradual, very slow, giving us a lot of time to be able to make a diagnosis. So in every 1 million of patients that are affected, around 10% are going to develop precancerous changes in the cervical tissue. The rest, the cancer will remain stable or regress spontaneously without any intervention. So this is just a graph showing you that if the initial sexual encounter of a young lady is at 15 years and they get the human papillomavirus infection, it takes a number of years to develop a precancerous lesion, say 10 years at the age of 25, and it also takes another 15 years for the malignancy to develop. And when round the world, a study was done about, the issues surrounding initial sexual exposure, if around the age of 15 years, cervical cancer will then develop over the age of 30 years. And this is just a demonstration that it gives us time to find it. So the precancerous lesions then will be seen in women in their 30 to 40 years if their initial sexual encounter was in their teens. Now, some women will only develop these precancerous lesions in the outer layers of the cervix, which we call carcinoma in situ, without becoming invasive. 1.6% will develop invasive cancer unless this CIS is detected and treated. So you can see the number of women getting cervical cancer. These 1.4 million women, a significant percentage of women had HPV that regressed spontaneously or regressed on its own, and many who developed initial precancerous lesions that were diagnosed and treated survive and completely get cured. Now, looking at the number of women in Kenya who have cervical cancer, who now present with abnormal vaginal bleeding or discharge, low abdominal pain. By the time flank pain is developing, it means there is bladder infiltration and probably what we call hydronephrosis. There's usually leg pain and swelling, kidney obstruction, blood in urine, constipation, development of fistula. Fistulas are abnormal communication because cancer cells usually infiltrate other cells. So from the cervix, they'll infiltrate the vagina, as I have demonstrated in the diagram, infiltrate the uterine wall and cause bleeding pervaginally. They'll also go posteriorly and infiltrate the rectum. They'll also go anteriorly and infiltrate the bladder, create an abnormal communication between the bladder and the vagina, where urine comes out through the vagina in what we call a vesical vaginal fistula. And when it grows posteriorly into the rectum and forms what we call a rectovaginal fistula. This is a very depressing sort of thing for women. So what are the risk factors that I've mentioned for human papillomavirus infection and cervical cancer? It is having early sexual activity. Sometimes the risk is increased with the number of exposures you get. So having multiple sexual partners or having a partner who has many sexual partners. And then, of course, as you get exposed to human papillomavirus, also exposure to other sexually transmitted infections. It has been shown, for example, if there is another sexually transmitted infection changing the cells, these changes in the cells are going to potentiate changes into cervical cancer. For example, in 1993, cancer of the cervix was associated with HIV, and a few years ago was an AIDS-defining illness. Now, sometimes it tends to cluster in families, but probably this is because of social cultural similarities in families about surrounding sexual behavior. Now, if you've had a previous abnormal pap smear due to other infections, is also an increased risk to developing cervical cancer, also based on what intervention was done to treat those abnormal precancerous lesions. There is an association with smoking, and smoking potentiates malignancies by making cells more amenable to progression into premalignant lesions compared to non-smoking women who have a higher chance of the changes regressing spontaneously over time. And as I've mentioned, where there is immune suppression, where the immune system cannot fight the HPV, either because of AIDS or other immune suppressive conditions, including diabetes, chronic corticosteroid use. So almost half of the 39.5 million living with HIV/AIDS in 2006, half were women. And this this association with heterosexual transmission of HIV was also associated with the mode of transmission of cervical cancer. I must emphasize that infection with HPV is so common that it's not a demonstration of promiscuity. Women should not carry that label that they are promiscuous and that's why they have HPV. Sometimes even just being married and, just the fact that the husband may have had a sexual partner, even one, can predispose a woman to the infection. So in HIV-infected women, it gets detected more frequently and tends to resolve more slowly because of the changes in the cells, and then is usually more difficult to treat, and the progression to cancer tends to be accelerated because of the potentiation and the changes that are already on the cervix due to HIV infection. And I must say this also goes for other sexually transmitted illnesses. Now, the changes that the cervix goes through when a young lady starts menstruating also increases the risk of developing a HPV infection and development of cervical cancer. So young ladies will usually have what we call columnar cells, which in my slide sort of look dark at the cervical os, and we call it columnar epithelium. On the surface of the cell, they are called columnar cells. Now, as a lady, changes through puberty, as her breasts are growing, she's starting to menstruate, getting body hair, these cells also change throughout these reproductive years, and these changes to squamous cells make the cervix more amenable to damage during sexual activity, to damage due to sexually transmitted infection, damage during childbirth, and these changes also predispose women as they grow older to cervical cancer. So screening for precancer cervical lesions led to marked reduction in cervical cancer deaths by 70%. Now, this is a demonstration of how a screening test or a pap smear for cervical cancer is done. This is a woman in lithotomy position or with her legs apart and with her legs folded. And the doctor puts in a speculum that opens the vaginal wall. And then the doctor takes a swab. That's a swab. And he's going to clean around the cervical os. So the cervix is the closure of the womb. The cervix, when is working well, prevents the baby from falling out of the womb. So it's sort of the purse string or the closure of the uterus. So the doctor will take, it looks like, when you look, they describe it as lips, tightly closed together. And the doctor takes a smear from that and puts it on a slide. And then they look at the cells and they can be able to see if there are any changes. And based on those changes, whether they are low-grade changes, whether they're invasive changes. It advises the treatment that the woman should get. Sometimes you're told by the doctor that all they can see is vaginosis or infection, and women are treated with an antibiotic, and that clears the infection. So it is very clear that if you prevent human papillomavirus infection, you will prevent over 99.7% of cervical cancer. And some of this prevention can be done by getting vaccinated. So vaccines are given to the population at the age of 9 to 12. And I'll explain why these ages were selected, as I've explained about the changes that occur to the cells during puberty. So if the vaccine is given early, sometimes you prevent those changes that predispose a cervix to getting changed by HPV. It has also been shown that if this vaccine is given at an early age, the formation of antibodies is more robust. And even if there is an exposure to HPV, the cells will not change, the infection will regress spontaneously, and the woman will not develop cervical cancer. So getting tested for HPV also, HPV DNA titers and measurements can also help in preventing cervical cancer by advising certain interventions. Use of barrier methods during sexual intercourse, including condoms, and of course, avoiding direct penile contact. So in primary prevention, a vaccine is the most effective way to prevent cervical cancer, and it will protect women against certain types of HPV. And it contains a mixture of virus types, and I'll talk about the two types of the Gardasil and the other vaccine that we have. So a secondary prevention, women already infected with HPV should be screened to determine whether they have early, easily treatable precancerous lesions. And a pap smear is the most well-established screening method. We have other methods, especially we use when we go to the field to do screening and we don't have a pathologist with us to look under the microscope at the slide. We do what we call visual inspection. We stain the cervix with acetic acid, and the changes that occur around the cervix can tell us whether there is a precancerous lesion or an early cancerous lesion. And of course, doing HPV tests. These are more technical and done in hospital situations. And of course, they are developed automated cytology screening tests nowadays. So pap smears are, they have many steps, doing the speculum, taking the swab, and sometimes this in low resource settings, it's a little tricky because you need a pathologist or a cytologist, you need a microscope, you need the swab. Visual inspection with acetic acid tends to be cheaper. And remember, in majority of these women, already precancerous lesions exist and are anatomically visible. So there's no need of doing a HPV test or even doing cytology. They are visible, they can be seen. So when you take a biopsy, you already know what to expect. So visual inspection with acetic acid is a technique where you just apply a dilute acetic acid, and what happens is that the areas that have cancer will basically whiten, as can be seen in that photo that I've shown. So when you stain with acetic acid, so you take the swab that I showed you at the pap smear, you dip it in acetic acid, you color the cervix, and then the negative one will look a little reddish, the positive ones will change white. Now, a positive result can be followed by immediate treatment using what we call LIPS or colposcopy that I'll explain in a while, or what we call a cone biopsy. I remember a few years ago, the former First Lady, when she was chair of the First Ladies Initiative to wipe out cervical cancer, had organized a screening at Kenyatta International Conference Center, where they were doing visual inspection screening, and immediately they do the LIPS procedure to treat while you're still in lithotomy position. They stain the cervix, They see the cancerous changes and they treat, such that when you come out of that position, your cervical cancer has been sorted out, the precancerous lesion is no more, and therefore no progression to invasive cancer. And that saved many, many lives. And later on, the woman will still need to go for pap smears and survive and the test, just to make sure that this has been cleared. So the only problem is that it is subjective, and it requires quite a bit of training. Many nurses in Kenya are actually trained to do this, but not empowered, and this has not been rolled out in many places in Kenya. It is very effective. It has fewer logistic and technical constraints, and it has been studied in low resource settings in South Africa, India, Zimbabwe, as a very good alternative to pap smears. So it's a very viable option for one-stop shop in our low resource settings. Sometimes we go out to the field to screen, and we notice these pre-malignant or even invasive cancer changes in women. Now, to tell them they've walked long distances to come for the screening, to tell them now go to Kenyatta for treatment, or we are referring you to this district hospital for LIPS procedure, sometimes they never come back. So I'd like to talk a little bit about a colposcope, which is an instrument that helps to also make a diagnosis of cervical cancer. And it is a next step in a hospital situation for patients with a positive screening result. That is, their visual inspection with acetic acid or their pap smear is positive. So we usually, it will commonly be done by a gynecologist or a clinical officer who is trained to verify the presence, the extent, and the type of precancer or cancerous lesion that has been done. It helps a biopsy to be done, and it also helps by looking at the extent, whether cryotherapy or LIPS or TA can actually be done. So unfortunately, it requires very high trained providers, and it's not an appropriate, screening tool. And of course, it's costly, and therefore, needs to really be considered in the rolling out in poor resource setting. But many women I know in the audience have access, but don't go. And they even have insurance, they have insurance covers that can be able to cover them for pap smears, for LIPS procedure, for HPV DNA titers, but they don't go. So nowadays, the colposcopes are being made into handheld equipment where we can go to the field and be able to even have digital cameras and so on to take photos of the cervical changes. So we've talked about the fact that cervical cancer is caused by persistent of the HPV infection. And I've talked about the different types of the virus. And I've talked about the high-risk genotypes that are more likely to progress to cancer. I've explained that it's a very slow-growing tumor, going through many years and many precancerous changes that provide opportunity to prevent, to early detect, and to treat. Cervical cancer can altogether be eliminated, and the screening reduced cervical cancer deaths by 70%. Remember why this is 70% is that some women are screened but do not follow up and do not follow through with the treatment. So I'll take a moment just to talk about the cervical cancer vaccine, which was a bit of topical issue and misunderstood, I think, in our setup. So the Center of Disease Prevention and FDA recommends that the vaccine to be given to 11 to 12-year-olds and to get 2 doses of HPV vaccine 6 to 12 months apart. It is best started at the age of 9 years, and only 2 doses are needed, and the first dose should be given before the 15th birthday. Now, teens and young adults who start later, around 15 to 26, need 3 doses of the HPV vaccine. Now, and also those people with a weak immune system, either because they had an organ transplant and they're on strong drugs, either they are HIV positive, they have very bad diabetes or another immunosuppressive illness, like having gotten a transplant and they are on immunosuppressive therapy. 3 doses are recommended from 9 to 26 years for these patients. Now, when the ministry had rolled out the program, there were several types of the cervical cancer vaccine. We have Gardasil, Gardasil 9, and Cervarix. When the ministry was rolling out, I think they had Gardasil and Cervarix. So there are these 3 types. There is the one that is quadrivalent and the one that is bivalent. The Cervarix is bivalent. It covers for 2 types of HPV. And I mentioned that these are 16 and 18 that cause most of the HPV. Now, the quadrivalent Gardasil covers for 4 types of HPV prevention. And of course, we have the Gardasil 9 that protects again 9 types of HPV types. And there was a bit of misunderstanding where they said that young girls, if vaccinated, will become promiscuous because they think that they are protected. But, they may not understand what sort of vaccine they are getting, just like they don't understand why they are getting the MMR vaccine, why they are getting the other vaccines, including hepatitis B that we give them. But it will protect them in later life greatly, greatly, greatly. And remember, the people who discovered the vaccine won a Nobel Prize because of the effect in prevention of mortality and morbidity in women around the world. The vaccination works very well. I think I cannot emphasize more greatly. And it reduces the number of precancerous lesions in young women, and it lasts a long time. So likely side effects, and there was a lot of drama around this, just like other vaccines when we took our children for vaccination. Even when you get a flu vaccine, you may get a bit of fever, a bit of redness around the area that you've been injected, a feeling of headache, tiredness, nausea, muscle or joint pains. There are a few cases with very severe reactions, just like in all other cases of vaccines, where they get severe allergic reactions. But I must say that these are very few, and therefore the vaccine is worthwhile because majority of people get no symptoms at all. And sometimes when you're taking your daughter for the vaccine, you can give them some paracetamol just to stop some of those mild side effects. Now, also to mention that the vaccine does not cover all, but covers most, and it does not treat pre-existing infections. We try to make, if a woman has been exposed after the age of 15, we give the 3 doses, but it will not treat pre-existing conditions. So even when you give 3 doses to people in their 20s, it's very important to continue with the ongoing screening. So it had been introduced to 85 countries by October 2018, but coverage is about 10%. And there are very few countries where this has been done, up to the WHO target of getting 90% of girls fully vaccinated. So the plan usually in a screening program is to screen and treat women to reduce the time, for women to receive treatment. So early detection by screening in all women in the target age group, followed by immediate treatment of the detected precancerous lesion, will prevent majority of cervical cancers. Now, cervical cancer screening should be performed at least once for every woman in the target group, at least once in your lifetime, where most benefit can be achieved. 70% of women screened with HPV tests between 35 and 45 years of age. And then, if one is found positive and treated, will be a significant improvement of survival in these women. So accordingly, effective and appropriate technology should be developed for the treatment of precancerous lesions. For example, the loop electrosurgical excision procedure that can be done even in the field with minimum side effects, and a woman can actually walk home, and use of cryotherapy or thermal ablation as well. So how do we manage once cancer has become invasive? So when we do, their abnormal cells. I've said that what we'll do is colposcopy. We'll do the loop electrosurgical excision procedure. This one uses electricity and burning around the cervical area that has been seen to be abnormal. Sometimes we do what is called a cone biopsy, removal of that abnormal part. We can do cryosurgery or what we call laser therapy. Now, cancer has developed further. It is now stage 1. Stage 1 is that it's an obvious growth that has been seen and biopsied. In early stage 1, where there is no involvement of lymph nodes, there is no extension downwards to the vagina, there is no extension backwards to the rectum and forward to the bladder, a hysterectomy can be done. That's removal of the uterus, of the fallopian tubes, everything. We come out with everything. And then we do a histology to confirm that indeed it was stage 1. And then depending on this stage, chemotherapy and radiotherapy can be done. I want to emphasize that when women have been diagnosed with invasive cervical cancer, you had a pap smear, a biopsy was done, cancer was seen, it's an obvious growth. It's very important for examination under anesthesia to be done. Because if there is involvement of what we call the parametrium or the walls of the pelvis, a surgery should not be done because the cancer will recur. So an examination under anesthesia for this advanced cancer is very important for complete staging. And sometimes in advanced disease, we even go to the extent of doing a PET CT scan so that we can make sure that there is no metastatic lesion to the liver and the lung. For stage 2, when you've had examination and anesthesia, we don't offer surgery. We give you radiotherapy and chemotherapy. And I must emphasize a significant proportion of women still can be cured. So they still can be cured with this effective treatment. So proper staging is very important. So it is very important for all healthcare providers at all levels to be able to recognize the symptoms and signs of cervical cancer. And the definitive diagnosis of invasive cervical cancer is made by a biopsy. It must be biopsied. Some of those lesions we see may be fungal infections and other things. Well, highly unlikely in experienced eyes, but we always insist on seeing a histology. And as I've mentioned, those options of management need to be really guided by what the stage is. If left untreated, invasive cervical cancer will progress. It will cause significant morbidity with fistulas, leaking urine, stool, pain, bleeding, and it is almost always fatal. It will kill the patient. Now, linking cervical cancer screening and treatment to other services, like you're taking your baby for vaccination, you're offered a pap smear at the spot. You're going to antenatal clinic, you're offered a pap smear at that spot. So you're going for, other tests, TB screening in this, as universal health coverage gets rolled out, and in provision of primary health services, cervical cancer screening should be offered. However, usually these services are separate, so women have to really go and look for this service. They don't have easy access. And, women, because of economic empowerment, have really, poor health-seeking behavior. They are not the economic providers in families in a majority of cases. And, living hand to mouth, the priorities are different, leading to a poor health status. Cervical cancer prevention must be integrated to the existing reproductive healthcare services, where you're going for contraceptive, for antenatal care, for other health services, so that we can save the lives of many women in our country. So thank you very much. So Zainab, I'm ready to take questions. There is one question I can start by answering. Yes, a pap smear is a screening method. Just as I mentioned, a pap smear, I showed exactly how a pap smear is done. And I explained that it will be the cells that are taken, are put, that's a screening test. That's a pap smear. The cells are scrapped from the cervix, examined under a microscope to check for disease or other problems. So we'll be able to pick bacteria, viral infections, precancerous changes in that cervix that looks very normal. So that was one question.
Okay, Dr. We have another one. I have Bernard who is asking, I don't know if you can see it clearly on your side. Scrolling. Give me a second. I see if I'm able to raise him again. Let me start with Atieno Oduol. Atieno is asking, she's not within the country, but she would want to understand the HPV vaccine. Is it only available to the 14-year-old women, or can it be given to women who are above maybe the age of 30?
So Atieno, thank you for the very good question. The HPV virus is recommended for young girls from the age of 9. I must also say that there is research being done now for the vaccine to be offered to men and boys as well in future. Now, as it, because the transmission is through heterosexual intercourse. Now, so the recommendation for those who can have access privately, it's from the age of 9. In certain countries, to have wider outreach, it may be from the age of 12 or 14. So different governments, I know in Malawi, they were offering from the age of 9. In Rwanda, where they had very, very good uptake of the vaccine, it was offered from the age of 9. Now, as women grow older, because they've had sexual exposure, usually the vaccine cannot prevent HPV infection because their cervixes are already infected with HPV. Like I explained, the HPV may regress, disappear completely, and no changes occur in the cervix, or it may remain stable where it just causes a few changes in the cervical tissue, or it may progress to a precancerous lesion. That's why they must go for regular screening when they are older, in their 20s, in their 40s, and are already sexually active. Now, there are times when you find women who have not been exposed sexually and they want the HPV vaccine. But I emphasized in older women, because of the changes in the cervix, the effectiveness is a little less. The antibody formation is a little less when you're older. And I've said, even if you've been vaccinated, it's very important to continue screening. Now, Atieno, not everybody needs annual screening. There are women who will have a pap smear. This year it's normal, next year it's normal, and your doctor tells you, let's wait for 3 years before the next pap smear. So sometimes screening is individual based. There are people who get a pap smear today and they need a check in 3 months or 6 months based on the changes that the doctor saw. The intervention they did needs to be monitored to see that the infection has cleared. So I hope I have answered the question about are there other ways and about the vaccine. There is also a question about women with polycystic ovarian syndrome or cysts. No, this does not portend a higher risk to cervical cancer and to infection. That's an anonymous question. Naomi is asking, please let us know how one can detect if they have HPV, or should they just go for a checkup? Now, what we look for are the changes that the HPV causes, not the HPV itself. In a pap smear, we are looking at the cells to see, have they changed in any way? Do they have a precancerous lesion? However, there are ways of doing something we call human papillomavirus DNA that can be tested specifically in the pap smear specimen. However, proving that you have HPV does not guarantee that you're going to
Daktari, I think we have lost you. I don't know whether you have muted. Daktari, I don't know whether you can hear us. Kindly give us a minute. We try and get hold of Daktari.
For example, you are found with an abnormal pap smear, the doctor put you on antibiotics and
Daktari, we
recommended
lost
that
you at one point, so I really don't know where maybe you may need to repeat that.
to repeat. Okay, so
Yeah.
the question was, what is a previously abnormal pap smear? A previous abnormal pap smear means that you do a pap smear and you find that there are some precancerous changes in the cells. The doctor may find a bacterial infection, a viral infection. You're put on treatment. So it's very important for the doctor to go back after 3 months, after 6 months, after a year to confirm that the intervention he did got rid of the infection. So if you've had a previously abnormal pap smear, then you're at risk of developing cervical cancer if it was not attended to and if it was not confirmed that it has completely resolved. Now I was explaining in this slide that you are found to have an abnormal precancerous lesion like low-grade squamous intraepithelial lesion or a bit of mild dysplasia. The doctor may decide to treat with drugs, to treat with a cone biopsy, to treat with the loop electrosurgical excision, to treat with cryosurgery or do some laser treatment. So he will recommend that because it was abnormal, because he wants to check if it has regressed spontaneously, is that he'll recommend that you get a pap smear. Now, if some abnormality has been detected, you're obviously at high risk of developing cervical cancer if this is not attended to, if the progression is not detected as well. I hope that answers the question.
Okay, thank you, Daktari. There's a question that came on very earlier on, and I would like you to address this one. Our guest says that she's about 25 years and her mother has recently died of cervical cancer. And she says she is a bit worried. Is she in the risk of getting the same?
Thank you for the question and very sorry about your mother. Now, cervical cancer per se has no genetic inheritance. The association in families is associated with sort of cultural issues like, if somebody smokes in the family, like your sister or brother, you're more likely to smoke, which increases risk of development to cervical cancer. Sexual behavior tends to also be cultural and sort of social in that you can have similar behavior patterns in the family, where, people are married to one man, in polygamous situations. So cervical cancer has sort of a social cultural association linked to behavior types. So she doesn't stand a genetic risk of getting cervical cancer because her mother had it, unless, of course, she also has an inherited condition that is immunosuppressive, where she's on immunosuppressive drugs. like, a lung condition that is inherited, but those are very limited sort of academic discussions. So to answer the question, no, there is no increased risk, but we really recommend that she also goes for screening so that she can, any changes in her cervix can be detected early and managed. And as I said, that completely alleviates the risk of developing invasive cancer and therefore curing the woman. In the center that I trained in England, cervical cancer was nowhere in the charts. In fact, the people who got treated for cervical cancer were immigrants, from East Africa, from Zambia, Zimbabwe, South Africa. The screening programs in Western countries are very robust, and women are almost forced to go to their primary care provider to make sure they get a pap smear, and it is in every sort of health facility. If you're going for antenatal care, if you're going for your contraception, if you're going for counseling, it is easily accessible and free to all women. And that has reduced cervical cancer completely from the charts in some of these countries, which is where we should be heading in Kenya. And the challenge is to insurance companies, please make sure that this screening is free and available to all people who are signed in with you. And for sure, this will translate to cheaper care, because treating people with cervical cancer with hysterectomy, with radiation and chemotherapy is by way more expensive than having sorted them out, vaccinated them, done pap smears, and sorted it out at precancerous stages.
Thank you, Dr. Kindly elaborate on our patients who have, because I'm seeing quite a lot of questions on the same, recurrent ladies who are suffering from ovarian cysts. Is there any connection with cancer of the cervix?
No connection with cancer of the cervix. However, some connection can be made with ovarian cancer. So I would like to emphasize that even if it doesn't portend a risk to developing cervical cancer, remember some of these things need to be investigated. Ovarian cysts can affect fertility. Ovarian cysts can develop into malignancies. Ovarian cysts can develop torsion, leading to significant pain in women. They also need to be investigated. Majority of them are completely benign, but because of those factors of production of hormones, cause of infertility, association with other factors like polycystic ovarian syndrome is associated with many other things, including diabetes and infertility. They should be investigated. But I emphasize no association with cervical cancer.
Thank you, Dr. Actually, there are so many questions on the screen, and we may not be able to tackle all of them at this particular time. We'll also be sharing them with Dr. so that Dr. can respond to them. You can also reach out to us and share the same questions on our cdm.wellness@apainsurance.org, or you can WhatsApp on 0706 600 577. I would like to give Dr. a minute just to explain to us where she can be found before I can give over to my colleague Gikami, who will do one or two questions, and then we can wind up because of time. Dr.
Asante sana. I just want to talking about the vaccine. Please take your young daughters for the vaccine, please. It no way translates to promiscuity. The vaccine does not protect from HIV, from other STIs, and from pregnancy. Please take your daughters for the vaccine. And also take your sons when data proves that it's also protective in men and therefore sparing women this disease. HPV can also cause penile cancers, although not as common as cervical cancer in women. I hope that's a good take-home message. Number two, some of the questions around the vaccine, like can older women get the HPV vaccine? I hope I've answered that effectively in my talk. I'd like to say that a frequent UTI is not a sign of cervical cancer. But please see the doctor, because frequent urine tract infections can mean that there is a higher ascending infection or pyelonephritis and infection that can lead to kidney problems. So please see your doctor, find out why you're having recurrent urine tract infections and get it effectively treated. Sometimes those women require cystoscopy, where the bladder is checked and cleaned up appropriately. Remember also there is something called bladder cancer that can manifest as frequent UTIs, but not to scare you, but just to say, please see the appropriate specialist. Having said that, there's somebody who's asked after a total abdominal hysterectomy and BSO, do you still need a pap smear? Eunice, the answer is no. But remember, there are some surgeons who do this surgery and leave the cervix intact. These are questions that you should ask your gynecologist. Did they remove everything and only leave a vaginal vault, or did they leave the cervical os intact? If they did, you still need a pap smear. If they didn't, you don't. How long should one do a pap smear? For as long as, for very, very long, as long as you have pre-malignant lesion or any changes that the doctor is concerned about. So I can see what you mean, Zainab. There are very, very many questions, and I hope I've answered many of them. Fibroids are not a sign of cervical cancer. That's a whole new topic. Of course, if somebody gets a hysterectomy, you can prevent cancer, but it's a rather drastic way of preventing cancer. I've answered about whether the cervix is removed during a hysterectomy. It may or may not be removed. I've answered that. The results of a pap smear can be immediate, right on the spot, if you have a pathologist on site. The reason why you don't get results immediately, sometimes it's taken to the lab for the pathologist to come and have a look, but the results can be available very, very quickly. When we did screening on site, we try and give the result on site so that women don't have to come back for results, because you lose many of them when you do that, especially in low resource settings. So having said that, I'm really grateful for having this opportunity to change a condition that has a great impact in our society. And especially to the quorum that I'm talking to today, you have access. You have access to everything. Cancer of the cervix should not be happening to us in this audience. And insurance companies like APA, a leader in the market, you should be offering cervical cancer screening opportunities to all women freely, liberally, and at any opportunity that they're able to. And you should also be offering, the vaccine. But having said that, I know I'm treading on waters that I'm not familiar with, and I'm available at the Nairobi Hospital. I do consult in other hospitals in Nairobi, but I'm based at the Nairobi Hospital at the Anderson Center on 2nd floor. Our office number is 0734 312 524 or 0714 805 164. And I will share my email address with Zainab, and I'm very happy to offer any responses that are going to impact positively in wiping out cervical cancer in our country. So Zainab, I think with those few remarks, I hope we've effectively conveyed this very, very important topic.
Daktari, yeah, thank you, Daktari. I think we have one or two questions that are really burning. Over to you, Gikami, just before Daktari leaves.
Daktari, we have a few gentlemen.
You're a little quiet. I can't hear you. Zainab, I can't hear the question.
We have a few gentlemen in our midst and would like to acknowledge their presence. I've picked a few questions that I'd like you to respond to. How can we as men contribute to cervical cancer prevention? And if men are the carriers, why not vaccinate men? And what is the worst that can happen to men with HPV?
Just repeat the first question, please.
To cervical cancer prevention. That came from a gentleman.
Oh, very, very good to take
Yeah.
that responsibility. One is probably a change in sort of sexual behavior, avoiding multiple sexual partners and using barrier methods of contraception during sexual intercourse can help men prevent cervical cancer in their women. That is one. Two, it is very, very possible that in the next few years, the vaccine will also be available to prevent HPV infection in men. The only reason it's not is that it has not shown evidence that it can prevent HPV infection in men. So the evidence was shown in women in preventing the changes in the cervix once they get HPV from men. So that is in the pipeline. There is a lot that has to do with the differences between men and women, the type of cells that propagate the virus, and therefore probably different initiatives. However, for the men in the audience, please take your daughters for the vaccine.
Apart from the HPV, Daktari, what can our men do? That is the next question.
It's to make sure that they don't. It is to encourage their women to go for pap smears and screening. That's one. Two, of course, is to prevent exposure as much as they can. Though I emphasize that it's so common that it's not a mark of promiscuity, but of course, as I explained, having one partner using barrier methods, not smoking, and so on can actually prevent this transmission. But most importantly is to encourage their spouses and partners to go for screening. That's the best they can do. And to offer the opportunities and good insurance covers like APA to their women so that they can have access to vaccination and to regular pap smears as needed. And early treatment if they have invasive cancer.
Thank you, Daktari, for letting us know that we should take the first front seat to ensure that we combat this cervical disease, not only for our sisters, mothers, and our spouses, but also even us as men. We have a role to play. So, and remain faithful. I'm being reminded here. So, at this juncture, we want to appreciate our audience for taking time to join us and learn more about cervical cancer. And we want to express our gratitude to you, Daktari, for taking your time in your busy schedules so that we have this discussion and be able to inform our clients, our friends and family on how we are able to manage, learn the symptoms and be able to encourage ourselves on the screening. I want to really extend our gratitude again to our delegates and our executive team in APA Insurance for giving us giving us time to learn more about this cancer. More so, we want to appreciate everyone for taking time to log in and every month we usually have these webinars, so we'll be sending invites to you and we appreciate you for logging in. For the question and answers, we'll of course Daktari share with you so that we can communicate more and be able to get back to our clients and give them feedback on the questions. So this time we want to thank you, Daktari. Thank you so much for taking your time in your busy schedules for helping us learn and getting more information on this cervical cancer. Asante sana.
Thank you very much too. Thank you very much and have a very blessed day.
Good day to you too. Thank you. Thank you, everyone. Have a nice day.